Welcome to TMA's Myositis Research Webinar. I am Rachel Bromley, TMA Senior Manager of Patient Education, Support, and Advocacy. We are so pleased to have with us today Dr. Mazen Dimachkie. He is a professor of neurology at the University of Kansas Medical Center and also actually the founder of this webinar. The Myositis Research Webinars was his idea, and it came to fruition this year, and we really appreciate it. Although I've been remiss to not have you on the actual webinar that you have almost created for us. So welcome.
Oh, thank you. Thank you. And it's a delightful pleasure to join TMA. And thank you for the kind invitation to do this. TMA has such a fundamental role in all the research that we do. And we're very grateful to this kind of patient community that comes together to support this worthy cause in approaching this extremely rare disease. So I'm going to start by, and my task today is to talk about research. As you see in a minute, I'll get to focus it on myositis research, particularly inclusion body myositis. But as we get started, I wanted to let you know about where I practice and what I see. Of course,
One moment, Dr. Dimachkie. I just wanted to let the audience know that at any point they can put a question in the Q&A. At the end, we will take questions. So go ahead. Thank you.
Yes, please do put your questions in the Q&A box. Look forward to answer them. So thank you for joining us and taking time, valuable time from your day to hear about IBM research. What we have, going back to what we have at the University of Kansas, is one of the largest clinical trials unit in North America. In addition to providing great education for fellows, we train fellows to become good neuromuscular specialists and treat IBM and myositis very well. We also have a large research unit. We have altogether 100 research studies going on in areas such as ALS, neuropathies, and nerve muscle junction disorders like myasthenia gravis, and muscle disease, particularly myositis. So out of the 100 studies we are involved in, 20 studies are related to myositis, and half of those have to do with IBM. And many of you would have heard about my focus and interest in inclusion body myositis. Why is that? IBM is the most common muscle disease after age 40. There's a unique pathology in IBM. There's a unique lack of response to treatment that occurs in IBM in comparison to other muscle inflammatory disease. We know we can treat dermatomyositis and reverse the weakness. We can treat the anti-synthetase syndrome. We can treat necrotizing autoimmune myopathy and reverse the weakness. IBM is really a difficult disease. And part of the difficulty is we still to this day don't know for sure what is driving inclusion body myositis. Is it the inflammation that we see in the muscle biopsy? Do the vacuoles and protein aggregates that we see on the muscle biopsy have to do with the disease? Is it stress inside the muscle fiber? Or is it the power plants that give energy to the muscle and all cells called mitochondria? Is it the mitochondria that are malfunctioning? Is it proteins that is being misprocessed or other signaling that's driving the disease? Altogether, we see abnormalities that implicate all of these in the pathogenesis in generating and causing IBM. And then the challenge is knowing which is the driver of disease at any point in time. And at different stages of the disease, I think there are different drivers in IBM that makes it even tougher challenge to treat patients with IBM or to find a treatment that works for patients with IBM. So with that, I'm going to start talking about a journey that started around 2006 with Dr. Barron at the time and Dr. Hanna in looking at a drug that was being tested in ALS. The drug's name is Arimoclomol. So in 2006, Dr. Richard Barron secured from a biotech company on the West Coast named Citrex, a drug and placebo, to do a pilot study in IBM of this drug. This drug is a molecular chaperone, which means it protects cells that are stressed by inducing heat shock proteins, and heat shock proteins are part of the chaperone protective mechanism for muscle cells and other cells. So we did a pilot study in collaboration with folks in London and the United Kingdom, where we enrolled 24 patients that got either Arimoclomol or placebo, and we observed something interesting in the way of a promising signal. It's a small study, early study, but we saw an early signal that's promising in something called the Inclusion Body Myositis Functional Rating Scale. And some of you may know this, what that is, but and some of you may just do your IBM FRS on your own, but that is a 10-question item. Each question is answered from 0 to 4. The questions, when they're labeled as 4, indicates normal, 0, cannot do, and there are gradations in between. 1 question addresses swallowing, 3 questions arm function, other 3 questions leg function, and the other 3 questions general body functions. So it gives you an idea that someone who has a really good score on the IBM FRS, a perfect score, that would be 40. The worst score, someone cannot do anything, they're weak, they can't swallow, they have a feeding tube, that would be a 0. So in the IBM FRS, in that pilot study, we did see a promising signal that we pursued after that. And I say we pursued it, and this started in 2006. So we get finally funded by the FDA Orphan Product Division to run this study. That's a large study now, not 24 patients anymore. We're talking about 150 patients that were randomized to receive either Arimoclomol or placebo. There were 11 sites in the US, plus KU, plus a site in the United Kingdom. And we ran this study in hopes to show that given the medication at a higher dose for a longer period of time would slow down the disease worsening over time as measured by the IBM FRS. Unfortunately, some of you may know this already. I presented some of that at previous TMA meetings about the promise of the study, hoping that it would tell us something good about it. However, the unfortunate reality is that this did not help slow down. This drug did not help slow down the rate of progression of IBM. Our paper was just published this month in Lancet Neurology. This is the phase 2/3 study of Arimoclomol in IBM. So it was really disappointing. All this work now, you can imagine, this is work that's gone on over more than a decade trying to see the promise of a drug that tells you how slow research is in IBM and how dire the need is. So we're not putting our eggs all in one basket. In addition to this approach, currently, I'm running a study looking at the possibility of extracting stem cells from the abdominal fat layer and seeing if injecting those stem cells are safe and possibly leading to a next phase study. So this is an early phase study. We enrolled 9 patients in this study. What goes on, as is going on today, we have a patient that's doing this today, our 9th patient. That we have the liposuction procedure by a plastic surgeon performed. The material from the liposuction goes to the laboratory of the stem cell center. They process, extract out of the adipose tissue the stem cells, and I inject those in the arm and thigh muscle on one side in patients with IBM, those stem cells. And the idea behind that is we hope that some of those stem cells will go back and evolve into muscle fibers by fusing with different precursors of muscle fibers. But we know that stem cells can modulate the immune system. So the inflammation in the muscle that is there can be attenuated by given injections of stem cells. We also know that these stem cells can promote blood vessel growth, and they reduce scarring. Fibrosis is reduced. So this is a safety study. This is an early phase study with a look as to what to do beyond that and planning. We're currently in the planning stages of what would be the next step beyond this study that we're conducting here at the KUMC. And some of our patients come to us from far distance. Today our patient comes to us from Wisconsin to participate in this study. And we've had patients come to us from the East Coast, West Coast, for different studies that we've been involved in. Now, this next study that I'll tell you about, one of our patients came from Montana, actually, to be part of this study. This is the safety and tolerability of a drug called phenylbutyrate. We conducted the study, we completed it, we put the paper up for publication. It's not yet accepted for publication, but phenylbutyrate is an interesting drug. It's a chemical chaperone. It's approved by the US FDA for something called urea cycle disorders. And with it being a chaperone, we got interested in it. And with the positive data that came out from using this drug in ALS and the FDA approval of this drug in ALS, mind you, when it was approved for ALS, it was this drug in combination with something called TUDCA, TUDCA, TUDCA. So with that in mind, we got excited about this and thought that we should do this pilot study on 10 patients with a 3-month lead-in period where we observed the patients. After that, they got the phenylbutyrate for 3 months. And we did different biomarkers. And one of the biomarkers gave us an encouraging signal as to some possibility that this drug can be beneficial. So this month, actually in 8 days, we're submitting a grant application to the FDA. Dr. Barron is leading that effort. I'm the co-investigator on the study to try to get funding so that we can investigate the role of phenylbutyrate in inclusion body myositis. Now, this is not all the story. I promised you we're doing a lot of IBM studies, and yes, we are. The next study that I'm going to tell you about is a study you may have heard about. It has a cute name, Optimism in IBM. And the study is actually a multi-continent study involving Australia, US, and Europe. And it's an academic study started by the investigators, academic investigators. In Australia, it was started by Dr. Mary Lee Needham. In the US, it was started by yours truly. And in Europe, by Umesh Bedreising out of the Netherlands. And so in this study, and the reason why we're doing this study is, what is sirolimus? The drug that's being tested here is called sirolimus. Well, it's a transplant rejection medication. It reduces inflammation. It suppresses what's called clonal T cell expansion. And what that means is that when you have a reaction to the tissue, a certain group of T cells attacking the tissue gets amplified. And so in this context, blocking that is good, especially since we know there's inflammation in the muscle tissue of IBM, and it promotes the rebalancing of the inflammatory cells. There's a group of inflammatory cells called Tregs. They're regulatory cells. They turn down the inflammation. So we promote with this drug the turning down of inflammation. Not only that, it improves the function of those power plants inside the cells, the mitochondria. So that's the mechanism of action. But why are we doing a large phase study right now across 3 continents? It's because early on and before the study, our friend and colleague in Paris at the Salpêtrière, Olivier Benveniste, conducted a smaller study, 44 IBM patients, 22 got sirolimus, 22 got placebo, and he did different testing methods. In any study, there's something called the primary outcome, which is the measuring stick for success. And there's a secondary outcome measures. The primary outcome in this was how strong the quadriceps thigh muscle was it was not evident that there was a benefit there based on the primary, but there were other benefits in the secondary, in the 6-minute walk distance, the vital capacity, and there was a composite index for IBM that showed some signal. So because of that, right now we're doing this study. The study is ongoing in the US at 2 sites. KU started, and here recently, Johns Hopkins started enrollment, and we are grateful to the funding source. So the funding for this study comes from the Myositis Association. It's your dollars at work here supporting making this study a reality in the United States. Without that, we could not have done it. And of course, studies are costly, but every penny is helpful. And we're looking for additional funding so that we can offer more US participants the opportunity to be part of this trial. Now, these are the studies that are interventional that we are in charge of. I want to touch on a couple of other studies that are non-interventional that we are part of, more so trying to see, well, how can we measure worsening in IBM? Because if we can predict and know how the disease worsens over time, then perhaps what we can do is use a better measuring stick, more predictable stick, to measure progress of the disease and therefore have better chances of success in future studies. So one of these studies is called Inspire IBM. It's led by Tassin Mozaffar at UCI. I'm the co-principal investigator on the study and on the steering committee. And the idea is to look at different outcome measures, IBM FRS, 6-minute walk distance, grip strength, getting up from a chair, quad strength, measurements of swallow dysfunction, and tracking their progression over the course of 2 years in patients with IBM. And we're intending to submit to extend that beyond 2 years to better understand the natural course of progression. And part of the study is, and some of you may have heard about the antibodies in IBM, many of you have heard about it, is called CN1A antibody. Well, part of this study, we're collecting CN1A antibodies to look as to how frequent they happen, but also, is there a difference in the way IBM behaves if someone has a positive antibody or does not have the antibody? There's a line of thinking from earlier small studies that suggest that those with the antibody will do worse than those without the antibody. We don't know that for sure. We're trying to see if this study tells us, yes, this is the story. Another study that I am leading at KU here is looking at an area of IBM that's not very well studied. We know that IBM affects the legs. We know that IBM affects swallowing, but also the hands. So how do we test worsening of hand function? There's usually grip testing or pinch testing, but it's not that great. So we're right now conducting or about to start a study looking at a biosensor to measure hand function in people with IBM. We are also involved in studies that are out there in the world of pharma and participating in those. For example, many of you have heard about the Abcuro study looking at knocking down the white cells from the muscles of patients with IBM. We are participating in that study, and there are others in the pipeline that can talk about at a later point in time, should the opportunity come up and we're not under confidentiality of disclosure agreements and it becomes in the public domain. So IBM, there's a lot of research. There's a strong immediate need. It's a passion of mine, and I'm hopeful that as we continue on this path, and knowing from the volume of research studies that are developed in IBM and how interesting those mechanism of action of those newer therapeutics being tested, that we will get some treatments that are effective in the next few years. So at this point in time, I will stop and answer any questions you might have.
Okay, so you just brought up the sirolimus ABC 008 trial, and you may have already shared everything that you can share, but this person just wanted to know if you had any more insights regarding this trial.
So regarding the Abcuro study, I think that right now, the stage at which it is that there were different groups within the Abcuro study. There was a group A, then there's a group B of the study. So part of any study is making sure that there's no safety concern in the medication and evaluating them along the course of a study. So there is a evaluation ongoing right now that we're very hopeful will lead to opening of group B of the study. And soon enough, they should be in late this year. We're very optimistic that Abcuro, will start enrolling again, not only in the US, but in other places. So that's kind of where Abcuro is at, because some of you are very interested in that. I understand it's an exciting mechanism of action. It's very promising. And so, yeah, that's where we're at with the study. On the sirolimus, we anticipate Europe to be active in the first quarter of 2024. That's the anticipation, but US and Australia are actively enrolling right now, and we're hoping to get more funding so that we can enroll more in the US.
In regards to the Arimoclomol study, did it not reach its primary goal because of the short time frame, giving IBM slow progression? And basically, the question is, if it had gone on for longer, say 72 months, would there be a better chance of success for it?
Yeah, I mean, this is kind of the unknown question. My thinking is that when we went out to 20 months, which is, as you know, very close to 2 years, you would think that should have seen something. Now, if we had gone to longer, would have seen something different. Who knows? But your question is very apropos in the sense that we need more information on the natural trajectory of IBM. And right now, the Inspire Natural History study of IBM is going on for 2 years, and we plan to try to get it extended beyond that to better understand the disease trajectory. And if it is that we're seeing separation later in time, then maybe that would argue for a longer duration. Now, going back to Arimoclomol and trying to be, if you ask me, well, what's my opinion? Would 4 years have made a bigger, better difference than 2 years? Based on all the indicators that I saw, I didn't think that a longer duration was going to make a difference in this drug.
If you're still doing the natural history and it's only so many years, if we don't really, if we're not able to determine yet the full trajectory of the disease progression, how is it that so many people in our audience feel it's inevitable that they will end up in a wheelchair? I mean, what is the amount of variability that we know of now?
Yeah, there's quite a bit of variability in IBM. There's the middle of the road patient that is really progressing, and we think we can measure it in the way of decrease in the inclusion body myositis functional rating scale of roughly 3 points during the course of a year. However, some patients progress much more rapidly, as others progress slowly or seem like the disease is not progressing. So there's quite a bit of variability in the rate of progression and range of that variability. And that makes it a challenge to try to, design studies. So we rely on natural history studies to design those studies that tell us how much variability, because part of the analysis of what is a promising outcome is looking at two factors. One of them is how it changes over time under natural conditions, but also what is the standard deviation or variability. And taking those two into account tells you how robust an outcome measure can be and helps you with calculating the effect size that you would anticipate and maybe the sample size, or appropriately the sample size for the study.
How does one choose the criteria for clinical studies in terms of outcomes? I have IBM and have been receiving IVIG for about 9 months. While my IBM FRS score has only moved by 1 or 2 points over 9 months, my quality of life, including strength measured by dynamometer, ability to do daily tasks, walk longer and faster, documented by my PT, has improved significantly and was tangible within 3 months. Prior to IVIG, I was declining steadily despite PT. They are NT5C1A positive. They wonder if the IBM FRS is not sensitive enough to distinguish changes in these studies. Many IBM doctors say that IVIG does not work, yet my experience with it suggests otherwise. Any comments or thoughts about the metrics used to evaluate studies and to measure success?
Yeah, well, this is an important question too. You know, we rely on several different things in outcome measures. As a matter of fact, here recently in June of this year, there was a meeting of the European Neuromuscular Center where experts from around the world were gathered to talk about IBM diagnosis and measurement of worsening of disease over time in research studies. And we reviewed a lot of these outcome measures that are out there, anywhere from strength measurement all the way to IBM FRS, modifying time up and go, 6-minute walk distance, different questionnaires that can be employed in IBM. There's a promise hand questionnaire. There are some swallowing function questionnaires and tests that can be done for IBM. And it's a tough area because we don't have a lot of data. However, what we know is this, that regulators, meaning the FDA, and European medical agencies, EMA, when you meet with them and as part of the Arimoclomol in IBM, we had a Type C meeting with the regulators, with the FDA at the time, and proposed the IBM FRS as the primary outcome measure, and they had no objection to it. They thought it was relevant. So choice of outcome measure depends on data, but also depends on regulators. And there's differences, there are going to be differences, intrinsic differences between different outcome measures. That's why in research studies, though we choose a primary outcome measure for success, we have a list of at least 6 or 7 secondary outcome measures that are confirmatory. So let's say the IBM FRS improves, but in a study, or stabilizes, or does not get as bad as the placebo. You would like to see at the same time strength improving. You'd like to see at the same time 6-minute walk distance improving. You would like to see at the same time the modified time up and go getting in the right direction, so that you look at those secondary outcome measures to confirm what you're seeing with the primary outcome measure. When it's kind of divergent in different directions, it makes it more challenging to interpret research studies. Now, if the primary outcome is negative, that usually means that you cannot really, by rules of statistics, even if there's some signal in the secondary outcome measures, there's no way to evaluate that. You cannot do that and look at that evaluation. Now, in the Arimoclomol study, it was consistent across the primary and secondary outcome measures that we did not see a signal in favor of the Arimoclomol. Hopefully, that answers your question.
Thank you so much. Given the heterogeneity of the way IBM presents, do you think that we'll find out that it is actually several different diseases?
Possible. That's a quick answer, that we're dealing with several different diseases that kind of be lumped together as IBM. So far, it's not evident as to where to slice and dice with IBM.
What is the biggest challenge for patient recruitment and trials? Is it awareness, access, or something else?
I think that the inclusion criteria in studies can be challenging for some patients with IBM. Part of the issue is IBM is one of those diseases that sneaks up on you slowly over time, and there's a delay in diagnosis. And sometimes by the time the diagnosis is made, the disease is so advanced that the weakness is so pronounced, there's so much muscle damage that the likelihood of responding to a therapeutic becomes low and therefore disqualifies patients from participation. The other disqualifier from participation sometimes is distance. Someone that lives 300 miles away from a research center may have less access, especially if you have to fly. Getting up from a seat of an airline or airplane, that's quite difficult and challenging for many people. They may need help with that. Driving long distances is the alternative, but then clearly there are some distance logistical issues that get in the way because of the distinct mobility issues that occur in people with IBM. So trying to get it where the number and intensity of visits to come to sites, to the research site, is lower, trying to make it where some of the research visits can be done at home in the convenience of the home setting of the patients is important. Do you remember I mentioned to you that study we're doing for using biosensors to evaluate hand function in IBM? A lot of it will be done remotely. And we're trying to see if we can not just amplify the number of participants in research studies by being able to rely on remotely administered outcome measures. I see that signal. Thank you.
Someone liked the answer. What is the most promising path to finding treatments for IBM, in your opinion?
There's so much going on right now in IBM. There's so much hope and excitement. If it turns out that the inflammatory cells, knocking them down, especially those KLRG1 positive cells with the Apkuro drug, this would be a major game changer. The sirolimus is also an exciting study. But as to if we knew for sure which is the pathway for success, we would be there already. But I think we're trying very hard to get there. And we're not putting all our eggs in one basket.
What are your thoughts on the MINT study?
And study. So I'm trying to remember. Oh, yeah. This is the Dr. Agrawal study that you're referring to. We were actually a site. I'm on the steering committee of that study. I have so many studies that I have to reorient. But I think that's a good study. It's the main study kind of explores doing remote outcome measures in patients who have myositis and have interstitial lung disease to see how you can do spirometry and other pulmonary function measures without the patient coming to the research clinic and doing it in the convenience of their own town, local clinic, and be able to widen the ability of patients to have access to research studies. So that if we can show that this can be done in that context, in that setting, that this may be a proof for future studies that we should be more inclusive of people living in more rural areas to be able to have access to research. Yes, I think it's a good study.
Can you say more about your study to look at better measures of hand function?
I can tell you that we're about to start here. We're looking for a few people to participate in the study, and it's using sensors. We're going to evaluate leg mobility with those sensors. We're also going to evaluate hand function. Some of the evaluations will be done in the clinic, but most of the evaluations will be done at home with contact with the research coordinator, kind of talking with you, and either through Zoom or other methods in order to see how things are going. So it's kind of an exciting way of looking at it. And our goal is ultimately to get to fund a larger study using sensors down the road. By the way, we're doing this study without funding just because I think it's important. We're just making it happen.
Has there been any study to see if human growth hormone has any beneficial effect on IBM or negative effects?
Not seen any data on that. I'm not aware of any data on that.
Is there a way to get on waiting lists for future clinical trials?
If you contact my research team, and Ali, do you have Ali's email address, Rachel?
I do.
Ali
I can put it
Shearstone?
in the chat if that's okay.
That would be fine. If someone would
Okay.
like to be on the wait list, you can contact Ali Searstorf. Her last name now became Rousseau. She just got married recently. Ali Rousseau is probably easier to flows off your tongue better. But yeah, email Ali and she'll put you on the list. Yeah, we have a sizable list of patients that are interested in research, but certainly, who knows, you could be the next person.
I am over in my email getting the email for Allie.
Take your time, it's okay.
Yeah. The next question, newer data continues to indicate mitochondrial dysfunction is key in IBM. Are there any treatment alternatives or related trials planned?
Well, the answer is no treatment, but alternative trials planned. I think so. These are quick answers, aren't they?
I know, I needed you to talk longer.
No, but that's okay. That's okay. So basically, because of confidentiality agreements, I cannot divulge
Oh, that
information
makes
that's out
sense. Yes.
there that's in planning stages. But thank you for your understanding and patience. But clearly, the mitochondria as a target is worthwhile exploring. And who knows, there could be a study coming up soon on exploring that.
Okay, this person has had 2 muscle biopsies 4 years apart at the Mayo Clinic. Each pathology report said that along with the inclusion bodies and a diagnosis of SIBM, my muscle samples show both degeneration and regeneration. My symptoms appear to me to be progressing more slowly than other patients I know. Is muscle regeneration typical of others?
Well, the we see in patients with IBM, the typical signatures are those of inflammation, invasion of intact muscle fibers by inflammatory cells. We do see vacuoles. We see a deposition of proteins like TDP43 and P62. The amount of regenerating fibers across biopsies is really variable. It's on a case-by-case basis, so I'm afraid I don't have a whole lot more information for you on that topic.
As IBM appears to be primarily at some point to be an issue with protein synthesis / production problem within secondary effects on MHC-1 expression, inflammation, and muscle damage. And most studies to date only look at modulation of these secondary effects without even reproducible biologic or clinical outcome measures, especially as the disease has such heterogeneous course. Has anyone considered single cell RNA sequence? Do we have any results?
So usually when you do single cell RNA sequence, you would be looking at establishing, um, a genetic defect. You've seen a genetic defect on gene testing. You're trying to look at the sequencing of the RNA to see the impact of that change that's of unknown significance typically. And then you do that RNA sequencing experiment. However, uh, most of the patients, 99% of the patients with IBM are sporadic, meaning there's no known genetic connection. So it's really hard to do that. Now, there have been single cell experiments, but I'm not sure they've looked at RNA sequencing as such because of that lack of genetic connection in the way of known abnormalities in patients with IBM.
IBM is distinctly peculiar in that it affects us asymmetrically, affects certain muscles of the limbs earlier than others, and seems to spare muscles innervated by the cranial nerves, swallowing versus speech, mastication. Is there no clue to etiology here?
I mean, that's kind of one of the toughest questions as to why some muscle diseases affect certain muscles and spare other muscles. We have examples of that from other diseases. There's a muscular dystrophy called oculopharyngeal muscular dystrophy, where the eyelids are affected first, then swallowing, then the arm and leg muscles. Why does it occur in this sequence in a genetic disease? That other disease, OPMD, is a genetic disease. And so why does it occur in that sequence? We don't know. There must be a clue in there when it comes back to IBM, coming back to that. However, we don't know what that tells us right now.
In the Arimoclomol study, I understand that the group actually experienced more deterioration than the placebo group in the IBM FRS. Are there theories as to why that might have happened?
In that study, we always look at trajectory and we look at significance of difference. There was no statistically significant difference between the placebo and the arimoclomol group in the decline of the IBM-FRS.
Can you explain what IVIG is and how someone with IBM could get it if they wanted it?
Um, I don't prescribe my patients with IBM IVIG. I see sometimes um, where others might prescribe it. IVIG is a blood product. It's taken from thousands of blood donors. Into each vial, there'll be products from thousands of blood donors. And what it is they spin the blood down from donors and they take the plasma portion of the blood that contains the immunoglobulin and they purify it in big batches. And that's what IVIG is. It's the IgG gamma globulin that's purified. So in your gamma globulins, which are to protect you from bacterial infections, that's your antibodies. There's the IgG, IgM, IgA, IgD, and IgE. So it's specifically that IgG that's taken out. So that's what IVIG is. It's an immunoglobulin G. And we think by it going into your body, it can work through several different ways. It can cause, binding of bad antibodies, can cause suppression of production of antibody, promoting of trapping of Ig that's pathogenic in the cells, working on inhibiting membrane attack complex and complement. They're inhibiting cytokines, chemokines that are mediators of inflammation. And so it's a complex molecule where all of these mechanisms of action, when I spit them out to you, it means we don't know exactly where it works, but there are many theories about where it could be effective. And the interesting thing, in different diseases, it may have a more focus on one area of the immune system than another. Those areas that I mentioned could be more focused on one of those areas rather than others.
How do you predict AI or artificial intelligence will benefit future IBM research?
Um, I don't.
I have a
AI is an
feeling that was
interesting,
going to be your
well,
answer.
well, I don't know the answer to that. I think AI is interesting. It's scary at the same time. We'll
Mhm.
have to see how it can help us crack puzzles, including IBM. And I don't have an inside track on how it could do that.
Where can someone access and read the Arimoclomol report?
It's available online. If you put Arimoclomol in IBM, let me see if I do that right now on my Google search. Let me make sure I'm not telling you incorrectly. Arimoclomol. Okay, if you put Arimoclomol Lancet Neurology, then the paper comes up, and let's see you can see the abstract. If I click on the PDF, you can see the actual
I
full
see something that
paper.
says safety and efficacy of Arimoclomol for inclusion body. Is that it? I want
Yeah,
to put
so
it in the
basically
chat.
this is it. That's what it looked like. I'm sorry, I'm screen sharing
No, no,
without
no, that's
asking you
fine.
for,
Yeah,
but
perfect.
what
I will
I
put it in
put,
the chat.
right. So this is the link. If you want to copy, well, I can copy the link.
No, I
Try
got
this
it.
link.
Doing it.
You got it? Okay, good. So this is how you can access it. I'll stop sharing here.
Oh, hold on a minute. The one I have, I think, might be behind a paywall.
Let me copy this, put it in the chat. There's no guarantee because of my access through the university. It could be that I have, like uh, I may
Yes,
have
that makes
access to it
sense.
for free, but Rachel, I send it to you. Maybe you can share with the groups. Hopefully it works for the group and for you.
Okay, great. Um, let's see. What is your opinion of the mitochondria and its role in IBM?
I think the mitochondria clearly show pathology in people with IBM, whether you look at the light microscopy or you look at the other aspects of the mitochondria, it's something that should be explored.
Okay, I wanted everyone to know I went to his link in the chat and it when I clicked it, it went ahead and downloaded it on my computer. So you can access it that way. Okay, next question. What is TDP-43 and do you envision that it will factor into future IBM clinical trials?
Yeah, I mean, TDP-43 is called TAR DNA binding protein 43. That's what it stands for. This has first been described in patients with ALS, and TDP-43 is something that usually is in the nucleus of the cell. You know, cells have nucleus and then there's a cytoplasm. So it's in the nucleus. So it was noticed in the spinal cord of patients with ALS that the TDP-43, instead of being in the nucleus, had migrated to the cytoplasm. And then later on, it was discovered that in IBM, the same thing was happening, but not in the spinal cord cells, but in the muscle fibers, that TDP-43, instead of being in the nucleus, was moving to the cytoplasm and was thought to be as a protein aggregate. So targeting it and targeting aggregates is an interesting way of tackling IBM. So I think you have a good idea there. And this is one of the many ideas that we should explore in IBM.
Do you have any thoughts about recent reports of tolerogenic vaccines that are being studied to treat autoimmune diseases like MS? Would there be an application to IBM?
Possibly, but not something that I can envision on the short term.
Are most studies and trials done in the US? Do you know where in Europe most IBM studies are done?
That Europe is country dependent, even though it's a European Union. Depends where you are in Europe. There are different research centers that are doing IBM research. For example, Leiden is known in the Netherlands to do IBM research, University College London and Oxford in the UK. Similarly with Germany, there are other sites that are specific. So I think it's a little bit more country specific than you would think when it comes to that. And then, of course, you want to have more global engagement beyond the US and Europe, and that's a challenge. Sometimes Japan is included in studies, Tokyo and other places, but yeah.
How can we be involved in the hand function study?
You have the email contact of Ali Seersdorf Rousseau. So
Yes, I
please
put it
email
in
Ali.
I put it in the chat. Okay, I heard that some patients participated in a part of the Arimoclomol trial where they had MRIs. Can you tell us what was learned from that portion of the trial?
The next part that we're going to try to unpack from the study, absolutely. There were participants. Now that we published the main study, we're going to focus on the MRI data. There were participants in the US that came to University of Kansas that had imaging of their muscles, and those also in London, UK, had that. So we're hoping to sift through that data pretty soon.
Is an individual limited to being in one study at a time?
Well, one drug study at a time, the answer is yes. You cannot have multiple drugs at the same time. Otherwise, you will not know which is doing what.
Exactly. Any research on hereditary IBM? I've been diagnosed as having SIBM. However, my father had IBM. I would like to know what to discuss with my adult children. Should they be tested?
This brings up the distinction between HIBM and SIBM and familial IBM. We know that IBM can be 99% of the time is sporadic SIBM, 1% are HIBM. The HIBM have one of the known genes like valine containing protein, also known as VCP, that are problematic, or the GNE gene. GNE would be, inherited recessively, And that one, there's a study that currently is ongoing. I think it's Neuronext 109 is the name of that study that is evaluating a drug in that disease. Enrollment completed in that study. We're one of the participating sites. I'm sorry, I don't know why I didn't mention it, but that's fine. We were focusing on SIBM. Now, the familial IBM, they're part of the sporadic IBM, but the reason why we call them familial is because of this type of association within the same family, people without any genetic association, no Mendelian gene association, have IBM. So what does that mean? Well, it turns out that there's something called HLA, and there's some HLA that predispose people to autoimmune diseases. And it could be that clustering of the HLA is causing in the same family is causing that familial type of IBM rather than the HIBM type. A complex question. Maybe I confused it a little bit more than necessary, but there's HIBM, we find a gene, there's sporadic IBM, and in those sporadic, there's some that are familial because of HLA predisposing to autoimmune disease.
Do you feel the potential for a genetic cause has been adequately and completely evaluated?
Completely yes, completely no.
Are there any studies to see if consuming certain proteins are more likely to produce T cells than others? What proportion of T cells are usually in IBM patients?
Yeah, I mean, there's a lot of variability, and I don't think protein consumption, which is part of the question, I believe, would have no impact on that.
What is the follow-up on those in Australia who had the ABC 0008 drug, the Apcuro drug? I understand they have been on the medication for many months.
Yeah, I mean, of course, there are things that are available in the way of information, and there are some that are not so publicly available. What we can say is what the data was not concerning in Australia to the point whereby it was reasonable to launch into this phase study that is going on right now. And in this larger phase study, Group A finished, and Group B hopefully will be starting soon towards the end of this year.
All right. We have come to the last, not even a question. It's just something for you. If you have a question, put it in now. We still have a few more minutes before 1, or we can wrap it up. But the audience wanted us to please thank you, Dr. Dimachkie, for your aggressive execution of IBM trials. You are truly a leader in this space, and we are all very, very appreciative. And then, okay, ABC 008, go into open label. Okay.
That's a good question. Things that are confidential, I cannot discuss at this point in time. And so, but thank you for asking. It's a very appropriate question. By the way, thank you for the comment. And it's very gratifying when, you're doing this work. And of course, it's a passion of yours. And when it's well received on the patient side, it makes just a ton of difference. So thank you.
You are welcome. And we've got more questions coming in if you're okay. Will the new patients in the Apcuro trial have to pass the same inclusion criteria?
The inclusion criteria of studies in IBM since the Arimoclomol have become rather quite similar, because we know what is the middle of the road IBM patient that's not too advanced, that would hopefully show a signal in research studies. So there are some similarities, I would be guessing, across those studies since that time, but some individual differences too.
Will there be any trials to determine familiar IBM causes?
I'm not aware of any going on right now.
Okay. Is there a possibility that in a small proportion of people, while their family is not passing down myositis in a Mendelian manner, there is a smaller group of causal genes that could make myositis of various types clump in a family across generations, more than would be expected in a highly polygenic version of disease?
Yeah, this is a very good question. Could it be that we're dealing with a little bit more of a complex disease that could be caused by multiple genes ganging up together to cause IBM? We don't have evidence for that, but that's a very good question. It could be that there will be evidence for it in the future.
Okay, what is the role of gut biome in IBM?
There's always been an interest across different diseases with the biome. And this is the microbiome is the part of the organisms that are in your gut. And this is what modulates and interacts with your first line of defense. So when you eat food, the first line of defense is something called the gut-associated lymphoid system, GALT. And so with that, there's interest in that. I'm not aware of anything that is really, shall I say, actionable in the field of IBM when it comes to the gut microbiome.
What is the role of hormones in IBM?
There's no known role for hormones in IBM that we know of.
If I am improving and not progressing with using IVIG, would you recommend enrolling in the Abcuro trial? It sounds like I would need to stop IVIG in order to participate in it.
This is an individual question. Um, I try to refrain from giving individual medical advice, especially when it comes about stopping treatment and starting another treatment. And so this is something that you want to consult with your physician who's taking care of your IBM. If you need to have that addressed by an IBM expert, the Myositis Association can help guide you, who's close by to you as an expert that you can visit with and discuss that question. Keep in mind that the Abcuro study will allow for a limited number of patients to be enrolled. I mean, it's an international study, but it's going to be, unfortunately, not everybody will qualify. And even if they qualify, some people may not have the chance to get in. So, anyways, a lot of people will get in. But again, the numbers are not hundreds and hundreds of patients that are going to be enrolled in it in such a way that I think that, at least for the US, it's going to be quite a rush to get into that study.
Does restricted blood flow therapy help in strengthening muscles?
There's some data on that. There's a study that was done with blood flow restriction and exercise, whereby that intervention has led to improved outcome in a patient or two with IBM. We don't know how it works. It could be that this is through release of stem cells by blood flow restriction. However, there's not a large study that one can say, oh, yeah, that's the answer. I've seen some of my patients be interested in it and try it, but there's no large study to support its effectiveness.
Okay, I am there will be a copy of this recording put up on YouTube this week. We do not have written transcripts available at this time. I will look into that option for 2024 and find out what kind of labor and financial costs that might be. I know I like to read. I want to read the transcripts. I don't typically like to see videos, so I understand the need for that. So thank you so much, Dr. Dimachkie. We really appreciate you coming in. It was supposed to be a myositis research webinar, but everybody was so excited to see you. It kind of turned into an Ask the Doc, which is totally fine because we really appreciate you doing that. And we haven't had you on Ask the Doc yet. So we might need to pull you in for that for 2024, if you don't mind. Do you have
Love
any
it.
last thoughts?
Uh, I want to thank everybody. The questions that were easy were fun. The ones that were tough were even more fun. Thank you for your questions. Thank you for joining, and enjoy the rest of the day. Now I can get on to my next meeting, which starts now. All right. Take care, everyone.
Thank you. All right. Bye-bye.
Bye.